put the recording on. Okay, so yeah, thank you for coming to do this session for us. Really, really looking forward to it. If I could just let you introduce yourself, and then yeah, we'll start sharing some slides.
Hi, yeah, Peter Furlong. I work for an organisation called Change, Grow, Live, which is a national drug and alcohol charity across England and Scotland, and I'm the National Harm Reduction Lead.
I'll go next. My name is Shayla Schlossenberg. I am the Drug Service Coordinator at Release, and we provide free drugs and legal information as well as some advocacy services we'll talk about.
And I'm Stephen Cutter. I'm Head of Legal Services at Release, so a colleague of Shayla's, where we provide the information she's just talked about. So I'll pass over back to you for the moment, Tracy.
Thank you. So we're going to hear from Peter, Stephen and Shayla about sort of first, like what naloxone is, how it can be used, how you can use it in universities. And then we're going to also hear from Cardiff Met on their experience of introducing it on campus, or soon to introduce it on campus. Rachel, you've got your hand up, but I'm assuming that might just be a legacy hand from saying you were back. That's fine. Didn't know if you had an eager question. Okay, so are we happy with Peter going first to sort of do the introduction? Yeah. Do you want to share your slides, or would you like me to share and just tell me when to push through?
I'll see if I can get them up.
Okay.
Tracy, can you see that now?
We can. Yeah.
Yeah. Okay. Well, I've probably got too many slides, so we'll just see how we go, really. But if Shayla and Stephen want to jump in at any point, that's fine. We'll just, as we go through them. And I've sort of probably just aiming at people who may know not very much about naloxone or what it is. So if you do know about naloxone, it might be preaching to the converter, but we'll just fly through it anyway. And any questions, just give us a shout. So yeah, starting, what is naloxone? It's basically a medication that will, it's aimed to reverse the effects of an opiate overdose. And opiates, when I talk about opiates, we're talking about heroin, methadone, buprenorphine, which is another medicine similar to methadone, morphine, codeine, over-the-counter opiates as well. So any opiate, really. It works against all opiates. And it basically, when someone has an opiate overdose, they go into respiratory depression. So the brain stops telling the lungs to work, and your body goes into respiratory failure, which is the effects of an opiate overdose. And it works quite quickly, and it can save a person's life. It comes in two formulations, which I'll show you pictures of shortly. One's an intramuscular injection, prenoxide, and another one is a nasal spray, which come on the market in the UK about $2.19. So anyone can administer naloxone to save a life in an emergency. You don't have to be a medic or of any denomination. Anyone can step in and be a good citizen. We know that lots of overdose happens when people are around, so peers often see peers overdosing. And before we had naloxone, people were pretty helpless and used to run away and got scared because it was a drug overdose. But we've moved on a lot now, so having a naloxone kit available increases the chance of helping to save a life before it's too late. So over the last decade, really, we've been really working to widen availability. To if we had our way, we'd have it, in a bin in every bus stop that people could pick it up. But there's some restrictions to stopping us doing that. But we're still working to widen availability. So who can supply it? I mean, it is a prescription-only medicine. However, some changes were made back in 2015. That means drug treatment services in particular can supply it without a prescription now. That includes people who work for drug treatment services, volunteers, people who represent us, and other staff as well, such as police, hostel staff, hospital staff. People should be trained in how to use it. It's not really complicated how to train someone on how to use it, but we do need to make sure people are competent in it. And just some 5 top things to know. it is a rapid acting drug, but it can take about 2 to 3 minutes to kick in, really. So any scenes that you've seen on Pulp Fiction, stuff like that, ignore them. That's not really helpful. But yeah, it is rapid acting and should act within a few minutes. Having said that, it's only a temporary intervention. It will wear off after about 20 minutes. So if people have still got lots of opiates in the system, what happens when you inject naloxone? It goes to your receptor sites and knocks the opiates off your brain receptor sites, doesn't take them out of your body. So there is a risk if unless the person seeks medical attention, that they could go back into an opiate overdose. So it's a temporary intervention. So yeah, that's I've jumped ahead of myself there. It blocks the effects of opiates. It doesn't remove them from the body. So it's really important to remember. It buys time until medical help can be provided, and I'll talk through the process of how you use it in a minute. But 999 is always your first action if you discover anyone you think might have overdosed. We mustn't really leave people alone. It's a scary thing to come out of an opiate overdose and not realize what's happened, and you feel quite poorly as well. You're in withdrawal, so try and stay with the casualty. It's only effective in opiate overdose and won't have effect on other non-opiate drugs. However, we'll talk in a bit about the importance of if in doubt, use it, because it can't do any harm either. And there's lots of different situations we're finding lately that, yeah, we don't really know what's in the drugs. So other drugs that we find in toxicology reports, when unfortunately someone has a fatal overdose, has never changed over time, really. Well, it has, sorry, but the core things we find, the benzodiazepines and alcohol, I'll talk towards the end of the presentation about a change in the drug market, and now we're finding other things in there, but it's those commonly included drugs that we often see as well. So when Change Grow Live sort of offer training to people about using naloxone, we try and keep it quite simple, but to make sure these points are covered: how to recognize if you think someone's overdosed on opiates, how to respond, the simple recovery position, and how to use naloxone. It's also a good opportunity to sort of dispel any myths around opiate use and opiate users, and how to stop and help someone. Often I get the train into Euston and I walk down to King's Cross, and I see people who don't look so well, and I stop, check on them, but there's so many people who don't stop, and I think it's a fear thing, and there's nothing to be scared around with people who use opiates. It's this is an opportunity to dispel some of those myths. And it's important that when you've done the training that people do understand what they've been told, really, and how to use it. So I'll just run, these are risk factors we talk about in Change Grow Live when we talk about working with people who use, smoke, or inject illicit drugs. And the risk factors sort of stack up, really. So injecting is more dangerous than smoking, but smoking drugs you can still overdose. It's just a higher risk with injecting. Using more than one drug at a time, what we call stacking different drugs, especially sort of depressant drugs, all can have like a negative effect. Sometimes people come into some money, and that prompts them to use more drugs than they would normally do, or to use different drugs. So we have to watch when people get some cash. They're not expecting. Trying to do a lot more work around using a loan. There's a great app now that you can download called the Buddy Up app that Cranston have introduced. It's not really took off as much as what we'd hope, but we've got to keep trying to promote it. It's where people can sign into the app and get a buddy for when they are using a loan, to keep an eye on them, basically. Loss of tolerance. So classically, coming out of prison, your tolerance is really low, but even a couple of days in hospital can really affect someone's tolerance. So when they come back out, they're at risk again. Differences in purity of drugs. You might move to a different area, get a different dealer. Drugs will be very different, and your risk can change. And obviously, physical or mental health issues can be a factor as well. I won't go through all these, but basically, when you start or sort of come to the end of drug treatment, that can affect your risk factors. life events, you know, bereavement, certain times of the year. Not actually being in treatment in a drug treatment program is a higher risk factor, so that's also something to consider. So yeah, I mean, I did mention it earlier, but even though it's our main body of work, what we do, it's not just people who use illicit drugs who are at risk of overdose. So anyone who is prescribed opiate medication or buys opiate medication, either over the counter or illicitly, they're also at risk. So I'll just run through some signs and symptoms that we look for when we're looking for an opiate overdose. So first of all, the person looks unconscious, can't be woken as unrousable. So there's a difference in sort of being in what we call a decent gouge, a decent sort of part of enjoying the opiates that you've took to crossing a line, and I'll show you the visual really. So we would check that by someone being unresponsive to noise or touch. Just gently shaking them by the shoulder and shouting them should be enough. We often see a blue tinge to people's lips or the tip of the nose or around underneath their eyes. We call it like a rasping noise, so it's not so much a snore, which I'm told I do quite a lot, but I've never heard myself, but I've heard other people, and it's a snore, it's a light thing. But when people are going crossing that line, I'm going to show you, it turns into more of like a real rasp, a real unusual noise that should alert people to looking for an overdose. And yeah, no pulse is a good one. Pinpoint pupils is another. I often, when I'm looking at someone, I'll look at the chest and see if I can see the chest rising or moving. So just looking for those signs, really. A colleague of mine sort of sketched this for me. I'm not very good at sketching. He would say he isn't either, but basically, when someone first takes a drug, they're quite alert. They're responsive. They take the drug of choice. In this circumstance, we're going to talk about an opiate, and they become quite relaxed, quite a nice feeling, and enjoying their effect, but still able to maybe converse. And as the drug kicks in, you know, they might go to that snoring part. They might be in what I said, like a decent gouge. May have a difference in the body position, and the breathing may become shallow, even though they're still breathing. But then this danger line really is the real difficult one to determine. It's when they cross that really and they become unconscious. Difference between enjoying the opiate, effects and being sort of looking as if they're asleep to going into unconsciousness, and that's where ideally is the time to intervene. They become, as I said, unresponsive. The snoring type noise becomes worse, and they're really getting into the danger zone then, and this is where naloxone plays a pivotal point of having it readily available. So yeah, that just sort of explains about crossing that red line, and the amount of people who have near misses is it's unrecorded really, but we know it's high, but it's having the ability to keep an eye on people, and when breathing stops, that we can intervene. So I guess the first thing we tell people is always want to keep yourself safe. You know, there is nothing to be scared of, intervening in when someone's had an opiate overdose, but obviously you need to check the surroundings, make sure there's no dangerous objects around that you could stand on, and your personal safety comes first. But once you've done that, which can take only a couple of seconds, it's then about checking if the person is in that, has crossed that red line we've talked about, gently trying to rouse them, shake them, shout them. If for no more than 20 seconds, 10 seconds, you're not seeing the chest rising and falling, they're not responding to you, we have got to start thinking, okay, this looks like an overdose. And the first thing we should always do is call 999, or if you're with someone, get someone else to call 999 while you start your intervention really. So if they're not breathing normally, and this is a bit contentious with some people, others it isn't, but I do always say, if you are trained to give CPR and rescue breaths, you should be able to do that. Because if someone's not breathing and you can help them breathing by doing the CPR process, then you should do. So we would always call 999, give them naloxone, and if needed, apply the CPR process. We then look at every 2 to 3 minute intervals to make sure the person has not come back, and then give another dose. We'll talk about the dosing in a minute, and continue with your CPR. If the person is breathing normally, but they're not rousable, it's about calling 999 first. That slide's wrong. That should be up the top. Call 999 first, give them naloxone, get them in the recovery position, and again, repeat every 2 to 3 minutes. And we say it's as easy as ABC: ambulance, breathing, recovery. Ambulance, breathing, C in recovery position, and then naloxone. And always stay with the person till the paramedics arrive, which can take variable amounts of time depending on where you are in the country. So back to the choice of products. We've now got 2 choices of products. We've got the yellow box there is the injectable prenoxad intramuscular, and the Nixoid, which is a nasal spray. Both round about the same dose. The Nixoid is 1.8 milligrams. The prenoxad is 2 milligrams. The difference being in the prenoxad, these 5 doses of 0.4 milligrams, and in the Nixoid, when we give it out, comes in an orange box with 2 sprays in. It's just 1 dose at one time, so the lock goes in as you press the plunger. So in the prenoxad kit, when you open that yellow box, you'll have a pre-filled syringe and containing naloxone and 2 needles to attach. It should never be opened until you're actually in an emergency situation to protect the sterile nature of the equipment. And then the needle's attached to the syringe quite quickly, and a dose of 0.4 milligrams injected into either the upper arm or outer thigh muscle. And if needed, you can go straight through. I've used it straight through someone's jeans, and it's perfectly fine. We don't need to worry about, clothing. As I've said, the prenoxad has 5 doses in total, and they're each marked by a black line, so you can easily see what 1 dose is. And again, every 2 to 3 minutes until the person wakes up. The last bit is sort of something probably only affects our service users really, but in the 2 needles in the kit are only suitable for that syringe. So in needles and syringe schemes across the country, we provide things called low dead space needles. So for our service users, we always say don't open the kit and borrow them needles for anything at all, because it may prove the kit to render the kit to be useless really, because other needles aren't compatible at times. I don't know whether this will work. I'll give it a go. It's a video that shows you how easy it is to use. Let's see if this. I don't think you've got sound, have we? Oh, yeah. Is that okay, Tracy?
We haven't got sound. I think to get sound, you need to reshare it and tick use video.
Okay. Let me see if I can do that.
So yeah, if you stop sharing, and then if you push the share button again. So if you stop sharing completely, if you push the stop share button at the top.
Oh, can't really see that. Is that? I've got new share.
I can stop your share. I'll stop your sharing for you. If you go to share screen again.
Yeah.
When you click on the screen you want to share, at the bottom it says optimize for video clip.
Okay.
That should that way.
To use prenoxad injection, remove the wrapper using the tear strip. Twist the outer plastic box to break the seals and open. Take out the prenoxad injection syringe and one of the blue needle packets. 2 are supplied in case one is damaged or becomes contaminated, for example by being dropped on the floor. Peel back the backing paper from the needle packet and remove the needle, keeping it in its protective sheath. Unscrew the clear plastic top from the syringe. With the needle still in its sheath, screw the blue fitting onto the syringe. Holding the needle on the syringe with your thumbnail, gently twist the sheath and remove it. Twisting the needle sheath instead of pulling it avoids needle stick injury. Holding the syringe like a pen or dart, insert the needle at right angles into the outer thigh or upper arm muscle, through clothing if necessary. and inject to the first black line to give a 0.4 milliliter dose. Withdraw the needle and put the syringe with the needle still attached back into the cradle of the prenoxad injection case. If you need to give another dose, insert the syringe again near or around the same site and inject to the next black line. After using prenoxad injection, keep the syringe in the box and hand it to the ambulance crew so that they know it's been administered. Watch the main film so you'll know what to do if you suspect someone is experiencing an opioid or opioid-related overdose.
My screen's changed. Can you still see that screen?
Yeah.
So I'll just move on to the next. The next product is Nixoid, the nasal spray. So it can we give it out in an orange box, and inside the box is 2 of these nasal sprays. It's ready to use, and in bold there, it does not need priming. So it's important that you don't press the plunger until it's in someone's nasal cavity. And then, as I said earlier, the whole dose of 1.8 milligrams goes into the nostril. And then after 2 to 3 minutes, if that hasn't worked, we say go to the second kit and go in the alternative nostril, just in case there's any blockages there that's affected its absorption rates. If you've got further kits, you can keep using them until the person wakes up, really. Is that working okay, Stacey?
It currently says the video is age restricted.
Okay. And what I'll do, this one just shows you how to administer the nasal spray. You've got the slides, Stacey. If you want to share them with people, that's fine. Not sure how to get that up. There's another video about the recovery position. Would that be helpful, or do you want me to skip that?
I think if we can skip that for now,
Okay.
just so we've got time for the others.
It's basically saying, the recovery position is really important, and it's very simple to do. The video shows you how to do that. So if the person regains consciousness, as I said earlier, they're likely to be in some level of withdrawal from the opiates that they've used. So it's about really staying calm, explaining to the person you've had an overdose. We've brought you back using Naloxone. Most people will know what that is and understand that you're there to help. Agitation's a natural thing, if but it doesn't lead. In my experience, as long as you're calm, it's a calm environment. Quite often, the person does want to leave. They want to go and get more drugs just because they feel so bad. But quite often, telling them to wait for the ambulance, telling them that they're at risk, usually works. It's important that when we think back at what I said earlier, that after 20 minutes, the effects will wear off. So the opiates are still in that person's system. And then if that person consumes more opiates to stop feeling poorly because they've been put into withdrawal by the naloxone, the risk is also increased significantly. So, yeah, I've said it a few times, but always try and wait until the paramedics come. If the person, while you're waiting, slips back into any level of overdose, it's about, if you've got it available, applying more doses again every 2 to 3 minutes. And something I said earlier, someone asked me once, well, what if someone's had a heart attack and we inject naloxone into them? It won't make any difference. It won't do them any harm at all. Any of us could be injected with naloxone now. I was sat here and it wouldn't affect us in any adverse way. So I think it's, what I said is making sure that the key things that people understand about naloxone is the risks and the factors that can cause overdoses, how to recognise it, and always calling 999 is your first point of action. The recovery position, the administration of the naloxone, and just keep monitoring that situation every 2 to 3 minutes until the ambulance arrives. I think I've sort of said some of this, but just top takeaways really. It's only for opiates and it won't affect non-opiate drugs. It can be supplied to any person who comes in contact with opiate users, so that's important, or anyone who's at risk of an overdose, I would suggest now, given some of the changes in the drug market, always call 999. Just going over what I've already said there, so we'll skip on. I mean, I wanted to put this in really. It's an addition to the slides because we are seeing a change in the drug market now in the UK. A lot of that's come from the Taliban have banned the production of opium in Afghanistan, and traditionally in the UK we've got our heroin supplies from Afghanistan. So the US gets theirs from South America, places like Mexico. We've always got ours from Afghanistan. So this seems to be affecting the purity of drugs now and the availability of new synthetic opiates in that gap in the market. There's a suggestion that we could have a heroin drought in the UK, and we know the heroin purity has decreased over the last period. So we're seeing lots of different changes, but that information on the bottom of the slide is now out of date. We've had 65 deaths from last year to now of people using inadvertently, not knowingly, a drug called nitazines, which is a synthetic opiate. And the reason I thought it was important to include it in today's talk was the fact that we're also seeing nitazines in non-opiate drugs. So it's turning up in things like benzodiazepines. It's been found in some level of cocaine. It's in pills and powders, basically. So when someone takes a benzodiazepine, they wouldn't think they'd need naloxone because it's not an opiate. But actually, lots of the drugs now we're finding are be contaminated with things like nitazines and others like xylazine. So as you can see, it's a rising issue, really. That slide's already out of date, so it's an increase in that number. The situation in Scotland has really rapidly shot up with nitazines. And I seen a drug alert this morning from the Manchester early warning system where nitazines have been found in illicit Zopiclone, which is a commonly used sleeping tablet by GPs. You can buy these drugs illicitly, and it was tested by Wedinos, which is in Wales, and I think it was the first I've ever seen nitazines being found in Zopiclone, which that's a big surprise. So yeah, we are seeing them a lot. So I think it's just being aware that we're trying to say treat every drug as if it's something else, really. Again, another video, Tracy. I don't know whether you want to skip these because we can share the slides.
Can we for now and see if we've got time
Yeah.
at the end? I'm just conscious of time.
They're just two people's
Andrew, thanks.
Two people's experience of using naloxone and how it's worked for them, really. And that's it. So yeah, I hope that's covered what you needed. And any questions, feel free to shout.
Thank you, Peter. It's been really useful to just see the training for those who maybe don't know, haven't come into contact much with naloxone, but to also sort of understand how easy it is to be trained in it. If I know maybe some people would probably prefer like to look at the nasal spray, so please do watch the video of that. I know for some people that might seem like an easier option to use. And I know sort of some people might say that maybe opiate use in the student body is lower than some other drugs. And I suppose, yes, statistics show that, but as Peter just said, we know that there are now opiates coming into other drugs, and that's raising the concern in the student body. Unfortunately, we have seen opiate-related deaths in the student body as well. So although it might be lower, it's not non-existent. I mean, in the last month, I've been contacted by a group of parents in America whose children go to university in the UK and are concerned that the UK universities don't hold naloxone as they do in America, because their children are coming over to study here and are raising a little bit of a campaign around why aren't universities holding it here. So I'm going to pass over to Stephen and Shayla around sort of more of the logistics now of what that means to holding it in a university setting.
Thanks, Tracy. I just want to check, I know that Cardiff are due to speak in this period as well, and roughly how long are Cardiff hoping to speak for so that we can angle how long we're speaking for?
Neil, how long would you like for your?
I would imagine probably 2 minutes. It's not a massive thing to say yet. So yeah, really quickly actually. So yeah, go whatever.
Grand. Thanks, Neil. Tracy, have you got our slides there?
Oh, I have. Let me just open them.
Thank you, thank you.
Some of what Shayla and I are going to discuss now this afternoon is going to cross over quite a lot with what Peter said. And so we're happy to jump over things as is needed, so that everyone's got a chance to ask questions as well if they would like to. By way of introduction, both of us, as we said, work with the charity Release. So we've been around for sort of over 50 years, providing a variety of interventions and forms of advice to people who use drugs. And in recent years, we've done a lot of work with both student work. So we published a study a couple of years ago called Taking the Hit, which looked at the drug use amongst the student population. We've also published 2 reports on naloxone. One was Finding a Needle in a Haystack, and it's looking at the existing availability of naloxone, but also pushing for increased availability of it, given the vital role that it plays in saving people's lives. There is some information there about ourselves, and then I'm afraid, Tracy, each one of these policies pops up one by one, so we can jump through all of those. So there's an awful lot of work that we've done within both the sector, but also with the student population in the past, and we've done some work with SOS as well in the past on trying to encourage a harm reduction approach towards treating student drug use within the population. I just want to pass over to Shayla as well to talk about some of their work.
Thank you, thank you. So just one of my things that I like about Release is that we do a mix of policy and research work and the direct frontline work, both in the legal and the drugs team. But some of the relevance for this from the drugs team, and so we run a national helpline. People can call for harm reduction advice. We do some medical advocacy for patients that I'll talk about in a second that are trying to or who are within drug treatment systems. We also partner with external research bodies. So we are working with London School of Hygiene and Tropical Medicine on 2 different studies around improving different harm reduction practices in the country right now. And we convene the Drugs Monitoring Network. And I won't talk too much about that because Peter's already named, but we are in the Drugs Monitoring Network. We convene professionals and people who use drugs from around the country, and we're seeing more and more nitazines pop up in all sorts of surprising places. And so I just wanted to echo that even if we don't think of opioids as being a really prominent drug to respond to in student settings, they are sneaking up and we should just be prepared. Next slide, is that right? This is just about the advocacy work that Release does. So these figures are actually a little bit outdated. Our case loads are a bit bigger now, but we are supporting about 20 individuals, mainly people in drug treatment, to get what they need out of drug treatment systems. Some of those individuals that we support actually are young people in their early 20s now, who came to us via the helpline and called because they had been told that as young people, they basically weren't eligible in one way or another for drug treatment support. And we had to go to commissioners and services in those local areas and fight for them to get support. So we also know that, but while the numbers may be small, there are young people who are using opioids in these countries that are actually being turned away from care. And thankfully, in these 2 instances of the people we work with, they were able to call us and get support. But in how many other instances are young people being told, no, you're not eligible for support? And actually, that's the end of it for them. So really just want to echo to everyone on this call that there may be many more people than we've realized who would benefit from the support, but they've already been turned away or know a friend that's been turned away. And so they're not going to come forward. And instead, they're going to self and peer community manage their drug use. We go to the next slide.
So just to build really on what Peter had said, I know that in the past when we've done presentations to universities, that there's often a concern about, I'm being told that this is fine for me to do, but what is the actual legal basis for some of this? And so hopefully this will be of some reassurance in letting you know that there are legal bases in which you can start distributing naloxone, both amongst staff and also student populations. So as a starting point, naloxone is a prescription-only medicine, that it isn't a controlled drug under the Misuse of Drugs Act. And that means that some of the typical offences that you will see with controlled drugs don't apply to it. So there's no offence of being in possession of naloxone. There's not Under the Misuse of Drugs Act, an offence of supplying naloxone to someone else, though there are separate restrictions under 2 other pieces of law that do apply to naloxone, but I wouldn't get too worried about them because they're also really clear exemptions that you can utilise in order to help maintain the availability of it. Next slide, please. So the general rule, if you have a prescription-only medicine, is that they should only be sold or supplied to people who have a valid prescription for it. And this is a nightmare when it comes to increasing the availability of naloxone because most people are not going to engage with a GP in the first place, ask for a prescription, and then use that prescription to go down to a pharmacy. The whole purpose of naloxone is to provide life-saving interventions in an emergency. And that is a process that isn't very compatible with trying to save someone's life. So there are exemptions on the supply of naloxone that sort of take it outside of this general rule for prescription-only medicines. And I've also got a note on there that Peter was talking about there being both a nasal spray, but also an injectable form of naloxone. There is a general rule as well to be aware of, which is that you shouldn't be injecting someone else with a prescription-only medicine. But as with the sale and supply of naloxone, there are exemptions that cover that for life-saving interventions. And that's going to be really important then coming back to the training that you receive or that you're giving to people to make sure that people properly know when to identify a life-saving emergency. And then that will make injecting someone else sort of a much more reasonable course of action to be taken. Next slide, please. And then another click, because I think I've got a piece of text that's missing then. There we go. So there is a general rule that disapplies these restrictions for naloxone if certain conditions are met. And I want to go through these in stage just because there's an awful lot of words there. So if we can go on to the next slide, it will hopefully be a bit clearer. Let's give you some more clicks. There we go. So if you are employed or engaged in the provision of drug treatment services by, on behalf of, or under arrangements made by some of these public bodies, then you'll be allowed to supply or sell naloxone to other people. This means that there's effectively sort of around 11, 12 routes in which you can be authorised to do this. And Peter was sort of describing that you can have partnership agreements with your local drug treatment service, whereby either staff or students as well are seen as volunteers of the local drug treatment service. And in those cases, you would arguably be saying that you're now someone who is engaged in the provision of the drug treatment service under arrangements made by one of these other bodies, because in CGL's case, for example, it's very likely that in the local area, they've been commissioned by a local authority to provide drug treatment. And so by being a registered volunteer with the drug treatment service, you will fall within their umbrella of the exemption. And at this point, you'll be eligible either as a university to be supplied with naloxone, but also potentially if you're then having students as part of that volunteer agreement as well, you'll be authorised to have onward supply to these students if needed. And that's going to be key because, again, the likelihood is in the event of an overdose, it will be students with other students who are seeing this rather than a member of staff in the student union who's wandering around halls of residence. So it's really important to try and widen the availability as far as possible. Next slide, please. So if you fall within that first category, the next 2 stages to the exemption are really pretty clear. If you are within that group of people, then you can then supply the medication that's in the middle, which is described as naloxone hydrochloride. That covers both the intramuscular and the nasal spray format. So there's a clear exemption for naloxone. And then you can supply it in the event that it's required for the purpose of a life-saving emergency. There's no definition currently on what constitutes a life-saving emergency, but what has been accepted by the Department for Health and Social Care is that there is a need to make naloxone as widely available as possible. And that means that restricting its availability to a life-saving emergency that is happening in front of you now would be completely absurd because it would mean that this needs to happen outside a pharmacy and otherwise you can't supply it to anyone. So you can have anticipated emergencies where it's likely that the person who's being supplied with it is amongst a group of people who are more likely to come across an overdose. And that could be quite context specific, but it could also be quite broad in the event that, for example, Peter had the display there sort of showing the number of deaths that have resulted from nitazines and isonitazines, which is if you're in one of those areas where there's apparently a very large contamination of the local drug supply, it's quite possible that you will be one of the people who comes across this and that there would be a good reason to supply you with naloxone. Next slide, please. Just to clarify as well, there's a very similar exception that follows almost the exact same process on where it can be supplied from, because a prescription-only medication typically should only be provided through a pharmacist and by a pharmacist at a pharmacy. But as Peter was saying, the law had changed via these exceptions so that you can do this in a much wider range of context, and that would include then a drug treatment service, but also a drug treatment service providing it through volunteers and other volunteer arrangements. And I think he mentioned on one of his slides there that that can mean it can cover sort of local police forces, but also hostels, hotels, and other forms of accommodation where, again, it's more likely that the people working in those environments will be exposed to an overdose that they can help reverse. Next slide. Shayla.
Okay, so we're going to go through these questions quickly one by one. We kind of put all of them here at first to just time check ourselves. But I think that we can go through these, especially because a lot of the answers will start to sound similar. But I know sometimes when presented with the legal reasonings and the exceptions, if you're not a legal person, even though Stephen has kindly broken it down very well, it can be like, that sounds scary. Am I in trouble or not? And so I have put these into the am I in trouble or not? And the spoiler alert is in all instances, the question is, you are not in trouble, rock on, distribute naloxone. So the first one, if we can click, how do I get naloxone? And I think Peter's partially covered this. And as we've said, like probably most ideally, you have a relationship with your local drug treatment service. And that's either you want naloxone, that's usually if you want naloxone to distribute, but you can also just go to the drug treatment and get naloxone for you to have on your person to use if you ever come across somebody overdosing. There's some caveats about this as well, that if you just want to get naloxone and you don't want to be known by the drug treatment service, or there's not a convenient drug treatment service, thankfully, there's loads of other exempted services that can provide you with naloxone. And the one that I like to signpost a lot is Exchange Supplies. Exchange Supplies has an online training that you can complete, and you do a little quiz at the end. Once you've done the quiz successfully, and you can try however many times you need to go back to the learning materials, make sure you understand how to use naloxone, complete the quiz that shows you know how to use naloxone in the appropriate circumstances, then you can purchase naloxone from the Exchange Supplies website. And so obviously in that case, you are paying for it as opposed to receiving it for free from your drug treatment service, but there is an avenue there that you can signpost to folks as well. So get naloxone from your drug treatment service, get it from Exchange Supplies. And that's for you to use. If you want to distribute it, partner with your local drug service. Anything I've missed there? Cool. Can I carry it around? Yeah. That's just yes, yeah. Carry it around. Have you been trained to use it? Will be a helpful thing to you, like, because again, you need to make sure that if you are going to use it, if you're carrying it around, I assume it's because you want to use it in the appropriate circumstance. Make sure you're using it according to the training that Peter just provided you. And if you need a refresher on that training, hopefully materials will be circulated after this, I assume. But again, Exchange Supplies is a free training online as well. And if you simply search naloxone training free online, there's also one that's on the addiction professionals websites. There are loads, and they all cover that same A, B, C, M that Peter mentioned. And Peter, Stephen, jump in on me, as well as Peter, actually. You're welcome to jump in on me if I'm missing anything here. Do you want to do this one, Stephen?
Yeah, happy to.
Okay. Yeah.
So I mean, broadly, this one, as Shayla said, is go ahead. My only caveat on this point from the legal side is that, you know, can you give naloxone to a student? Is yes, in any situation, if it's for a life-saving emergency. So you can administer it to them if you think that a student is currently in overdose. There's no issues there whatsoever. The issue there could then be is sort of, it's more with a supply mind rather than like the administration side. So is, can I, as a member of staff who has naloxone, just give it to a student? And at that point, you're going to need to fall in sort of within the exceptions that we were talking about before. So that's, are you employed or engaged in the provision of drug treatment services? And that's when you're going to want to have those volunteer arrangements in place, just to make sure that your staff are covered by the exception. And then there's really no issue whatsoever about whether there's any non-exempted activities taking place.
That's it. I used to work in a drug treatment service, I will say, it's a sort of example, and we would train supported accommodation workers, so usually for the hostel sector in the homelessness world. And we would train them and have an agreement with them on paper so that they could train the people living in the accommodation and they could distribute the naloxone. And so the training that we gave as a drug treatment service to other people was a bit more rigorous because we were training them to train and answer questions. But we had an on-paper agreement, and then they could train the folks that lived in the accommodation and provide them the naloxone so that the residents could have it. Because we knew resident-to-resident administration of naloxone was still much more likely than staff-to-resident administration. And I suspect the same would be true for students. Okay, can we go to the next? Does anyone want to take a gander at the answer to this question? Am I allowed to source answers from the audience? Cool. What do people think?
I think I would, maybe you can if they are showing signs of an overdose.
Yeah, exactly that. If somebody is unconscious, which is one of the big signs of an overdose, right? You're not going to be able to easily wake them up and ask them, hey, are you having an overdose? Or if you can do that, then don't administer the naloxone because they're not having an overdose. At least not an opiate. So exactly that. So long as, again, you're following those trainings step by step, you're looking for those signs are in place. And the first bit of that training, you got to try and rouse them. But if they can't be roused, they're unconscious, then it makes sense. And sometimes like you may administer naloxone to somebody that is absolutely not having an overdose, and there's another medical reason that they're unconscious. The naloxone will not hurt that person. And the caveat here is if that person is opioid naive, meaning that like they don't generally have opioids in their body, they won't experience anything other than bruising if you were to inject them with that. If you administer it to somebody who is unconscious, not overdosing, but is usually opiate dependent, they will still also probably experience that acute withdrawal. But again, it wears off within those 20 minutes, like Peter said in his training. So in either which case, like you're acting in a life-saving like capacity, proceed. Thank you. This is just a recap of again, exactly what Peter had shown. And so this is just to emphasize that follow the training when you're not sure. And that if you look at resources online about training, there's slightly different tweaks for not breathing versus for breathing. If somebody is not breathing, you're actually calling 999 before you administer naloxone. This is the real emphasis of this. If somebody is breathing, you can get them into the recovery position and administer naloxone first. And this is breathing and non-responsive. And so either which way, you're calling 999 and 999 is going to support you with that person. But this was really just to emphasize, make sure you're following the steps, which can feel scary and hard to do when you're dealing with an emergency, like someone unconscious in front of you. And I train others. Stephen, I've rambled for a second. Would you like to start where I can?
Yeah, of course. And I think, again, coming back to the exceptions, it's going to depend on the arrangements you've got in place, which is so long as your chain begins with someone who's authorized to be distributing naloxone, then the likelihood is that you can also take part in providing the training. I suppose in the interest of making sure that people are as well trained as possible is whether you want to have a more formal arrangement with the local drug treatment service or using the training online with exchange supplies so that the people delivering the training are always the best people placed to deliver it. But in the absence of that, sort of knowing and understanding naloxone is going to be the most important thing.
Yeah, fully agree. I would just say, if it's a non-urgent situation, why go through the hassle when there's so many free, easy to access resources online? Signpost your friends and your peers in your community to them. Say like this exchange supplies thing is right here, and then chat through it with others and make sure you're all refreshing each other's knowledge. But like if you have access to resources that are part of that pipeline already, you may as well use them. Although I do think there's something to be said about peer-to-peer training as well in terms of listening and uptake. But yeah. If you're not part of that pipeline, basically, yeah, signpost to the folks that are, or become part of that pipeline and start volunteering for your drug service. Do I need proof that I've been trained? No. For the trainer, sometimes having a copy of proof for the sake of like data keeping and bookkeeping is handy. That's not even required. If you want proof that you've been trained, again, exchange supplies or the addiction professionals trainings online both provide certificates, and I believe lots of local drug treatment programs can provide a certificate upon request. So you can absolutely seek that out, but you don't need it to administer naloxone.
Before we go to questions, because I know they might be thinking of lots, and I know some people had questions because I know they were raising them before the meeting. But can I just pass over to Neil to give your sort of 5-10 minutes, however much you need on sort of what's happening at Cardiff Met around naloxone and what's sort of the plan and why you decided to do it.
Yeah, no worries, Tracy. There was a few bits of sort of fortuitously coincided, I guess. So obviously the start of the SOS program, and we had a bit of a restructure in terms of drug treatment services at Cardiff at the same time. So their capacity, really increased, and their interest in working with universities are really increased as well, Tracy. I heard yesterday they're looking to employ a harm reduction person just to work with universities in Cardiff too. So that's interesting. But anyway, so we'd already been having some conversations around naloxone early doors with our local service. And then at the start of this academic year, we'd had an incident with a student who was really intoxicated and needed to go to A&E. And then when some of the accommodation team actually went into his room, they found a large amount of ketamine and a large amount of opiates too. So it was almost, like I said, probably yesterday, it was almost a bit like a perfect storm in that regard. And we've had a couple of other situations this year where students were found with a mix of different types of drugs in their room too. So I thought, oh, well, let's start having a conversation about maybe looking at naloxone with accommodation services and our halls wardens and our security staff too. So I just had some initial conversations earlier this term. And to be honest, it was like pushing at an open door with the teams there. We've got a harm reduction approach as a university anyway, and sort of the leadership is signed up to our new statement and that sort of thing. So yeah, from that regard, it was quite a straightforward conversation, really. So at the end of this, well, actually, I'll go back a step, because the individual that I mentioned was homeless, so he was with us anyway while we were trying to get him out of university, because for a number of different reasons. But he stayed with us for a couple of months in halls, and he was staying with us over Christmas. So drug treatment services came in before Christmas and trained some of the security staff on the nasal spray with naloxone. So that happened as a sort of precautionary interim measure, sort of mitigation of any risk, but everything was fine anyway. And then they're coming in at the end of the month to do that longer training session. I think they do a drug awareness piece, and then the naloxone training, I think it's about 3 hours. So we've got the accommodation staff, security staff, and some of the wellbeing team staff just out of interest coming on that training at the end of this month. And I think maybe some of the SU as well. I'm if Will's on the call at the moment, but so yeah, that's kind of where we're at the moment. And from a point of view of, it's better to have it and not need it than need it and not have it, kind of thing, So that's where we're at. So yeah, that's my 2 or 3 minutes.
Thanks, Neil. And I think that's right what you said. It's better to have it and never need it than need it and not have it.
Yeah.
So has anyone got any questions for Peter, Stephen, Shayla, Neil? I know Becky had a question prepared before, so
Well, yeah, I'll just jump in. It's quite well timed, because me and my manager were going to have a meeting about writing a risk assessment for naloxone last week, and we've held off on that meeting for this session to take place. Neil, have you been asked to do a risk assessment about having naloxone on site?
Not specifically from accommodation services at the moment. There was a couple of comments around maybe some of the one or two of the wardens specifically not feeling very confident, I think, Becky, to be honest, in terms of using it. But I think they are going to come onto the training anyway. And I think the whole nasal option takes a little bit of the, I don't know, maybe any perceived threat away from it kind of thing.
Yeah.
So not yet.
Okay.
But that might I would anticipate that will
Sure.
and then I've started thinking a little bit then about that student communication piece in terms of, you know, where you go and that sort of thing too. And also then we've got nomination agreement with some private halls as well. So there's quite a lot of our students in Unite halls across the city. So that's another bit of work that you know, I'm going to need to sort of consider as part of this, or we need to consider as part of this whole thing. Yeah. So no, not at the moment, but
No.
yeah.
I've said it now, you'll be asked next week.
Yes. Yeah.
Cool. All right. Yeah, because I think we're doing this risk assessment because we've taken it to the sort of the senior exec level, and there's been a bit of pushback and a bit of sort of a lack of desire to put it in place, which is just really frustrating when it's, you know, it seems like a really simple, easy thing to do. And really effective.
Well, I communicated it upwards. You know, I've through my boss to our sponsor. So Will, who's on the call, they jointly signed the agreement for SOS. So nothing at the moment.
I think what you said, that like that fortuitous situation with that student probably made it really real and live and really relevant, quite, you know, a really like an open door with that situation going on. Whereas, you know, I think I'm getting a bit of feedback from sort of higher levels that like, oh, there is no opiates at UE. Which is really sweet and lovely idea, but just not true, is it? So, but I guess it's just a fine line to tread of not sort of freaking people out.
I suppose it's that you know, that's what senior managers are reputational risk in this. The reputational risk of potentially got a drug problem, or then you've got the whole reputational thing around, well, potentially we've either saved a life or somebody, you know, students lost their life because we didn't take that action. So it's it's a no to us, I suppose. It's a no-brainer, isn't it? But I guess higher up they've got a different
Calm. So I guess, like, from what I'm hearing from like the release guys, is like having a service level agreement or like something through the local drug service would be the best way to go about it and be seen as a volunteer for them, and then being able to distribute to students, because I do one-to-one appointments with students, and I am trained in naloxone. I work for Bristol Drugs Project. Historically, I've delivered naloxone training, so it's something I'm really versed in. But I've sort of had my hands tied all of a sudden being in this setting of not being able to offer that life-saving medication. But that's the sort of route you'd suggest, is approaching the local drug service and becoming a partner with them.
Yeah, definitely, Becky. And I think the drug service may already in your area have sort of pro forma agreements that you can use with them.
Sure.
And then that's something Shayla and I have been talking about trying to produce anyway, just to try and help get over some of the hurdles, because sometimes people want documentation, but no one's ever written it. So if you run into that hurdle, that's something we'd like to look at.
Yeah, brilliant. Because I know, you know, we used to distribute to staff who worked in hostels, and I thought it would, you know, a similar agreement to that, really. It's like you're likely to come into contact with somebody who would be needing it. And that's enough. Is like there's a likelihood that you might come across an opiate user.
No, that is enough.
It
shouldn't really, every service will have a slightly different looking version of this, or versions, because you'll usually have one that's like, say, with your hostels, and you might have had another that covers like peer-to-peer volunteers doing naloxone exchange. And so we're happy to work on one that is like slightly more standardized for unis. But absolutely, the hostels one tweaked is enough.
Yeah, brilliant. Great.
Thank you. And Pete, Stephen, Shayla, do you have any advice on risk assessments, or know any that are pre-written anywhere that would help Becky rather than writing one from scratch?
I don't. Oh, sorry, Peter.
Go on, Stephen, after you.
I was going to say I don't, so you might be more help. So.
I mean, we have had some hostels who've sort of, as you said earlier, the higher ups have insisted on having a risk assessment, even though it's not really needed. But I think some of our SLAs cover it as well. So I think we might have examples we can share. Let me have a look and I'll come back to you, Tracy. But the other thing I was going to say, Change Grow Live have been a bit slow on the uptake of a real national approach to peer-to-peer naloxone, and there's reasons for that, because we really wanted just to make sure that active drug users, people who are using drugs today, can take kits for their friends. As you've heard, it gets a bit complicated with it being a prescription-only medicine, and you should either work for us or volunteer for us. CGL have got a policy that you can't volunteer for us if you're using illicit drugs, which is daft, but that's what it is. So we are about to launch a national peer-to-peer naloxone scheme in March, which means anyone can be a peer activist, whether you're using drugs or not. But basically, if there's a Change Grow Live near you, and I've seen people from Northampton here and Manchester, a student could come in and say, I want to be a peer activist. They'll get the training, they get a couple of hours enhanced training. We'll give them an ID card to say they're a peer activist, and then they could take kits for their peers in uni. So that's one thing we can maybe keep an eye on. But yeah, risk assessments, I think it's just a bit risk averse. People sort of insist on them when there's no need for them.
Yeah, I think that's what we'll probably end up creating, is just something that sounds a bit daft, but if that's what keeps them happy.
Yeah.
I'll go to Jess.
I was just going to say, Peter, that peer activism program sounds really great. I know that it's not even started yet, so maybe you might not know the answer to this question, but obviously I'm in Belfast, and over here we're often quite separated from a lot of things. Would there be any capacity for like an online training program for people potentially in the future?
Well, yeah, as Sheila said, I think the Exchange Supplies online training is more than adequate. It's certificated, it covers all the bases. You can take it again if you fail, type of thing, and it's free. So I think the Exchange Supplies are willing for anyone to use their resources. So I think that's fine. And I think if you need more stuff for like what does it mean to be a peer activist, we could probably look at developing something quite quickly. Yeah.
I was just going to flag, are you connected with BB, Belfast Experts by Experience? Yes.
No, we've actually only just started this program, so no, I haven't heard of those yet. Would you be able to say that name again for me?
Yeah, Belfast Experts by Experience, and so the acronym is BB, BEBE. As a sort of local like drug users group in Belfast, but also might be able to help just on the ground with the idea of like what peer-to-peer work in Belfast might look like. Maybe worth connecting with, but definitely, like Peter said, I think the first step is just making sure everybody's really confident, and then loads of it from there. Like I think we can whip up various trainings, so on and so forth, but a lot of it is y'all will know your own student context best and the places to be in order to most effectively distribute naloxone, and it's just sort of getting the outreach skills from there to be in those